Obviously, schizophrenia, but what are the other indications? So in bipolar mania, sometimes you will see haloperidol or maybe chlorpromazine used, but these are generally reserved as already last line options since our preference is really in using mood stabilizers and second generation antipsychotics as well as certain antiepileptics. Tourette syndrome, haloperidol, along with aripiprazole later on, these are also approved for Tourette syndrome. This is a disorder involving tics. It can be movement in terms of involuntary movement, but as compared to dystonias, these are more stereotyped, there's a more pattern to them, as well as vocal tics. So there's that misconception that all vocal tics can involve cursing. No, that's not how Tourette syndrome works and can also be very debilitating. Behavior problems, but obviously this is something we reserve also last line as preferred still is non-pharmacologic, social support, and age-appropriate interventions. We're good at medication as future pharmacists, but we don't want to use them as a solution for everything, especially if there are non-pharmacologic interventions that can be used as first line, such as ABA or other things like, for example, how chlorpromazine is also occasionally used for intractable hiccups, main use for first generation antipsychotics just limited to schizophrenia and perhaps Tourette syndrome. So mechanism, you already talked about this, D2 receptor antagonism and HAM blockade. Onset of action, there are a few phases to it. The initial phase would involve agitation, aggression, increased motor activity. Those are the symptoms that are targeted first. And actually, there are certain D2 antagonists that can be used as interventions in acute agitation in what we call rapid tranquilization. However, rapid tranquilization is already reserved if the escalation techniques for people with acute psychotic episodes have already been exhausted and you have considered the person's advance directive. Anyway, the actual positive symptom benefit is observed still after several weeks. So give it 2 weeks. And the full response may take a month or more to occur. But basically, just so you're aware, it's not everything all at once. It's not like something like a benzodiazepine that have a 30-minute onset of action. This one may take a few days to 2 weeks for at least the positive symptoms. Administration can be divided into doses or once daily depending on which medication is being given. Of note here, we do have a dosage form called long-acting injectables. So these are depot injectables that you inject intramuscularly. Usually it's either the gluteal muscle or the deltoid muscle, and these will slowly release over time to provide sustained dosing. So meaning you administer once and you get everyday dosing all throughout up to your next dosing interval. Meaning for certain depots, you only have to come every 2 weeks at least, and the other depots sometimes every 6 weeks. It depends. Contraindications. You probably don't want to give flufenazine for hepatic disease because there's some hepatotoxicity there, as well as it's contraindicated in the depot injection, which is what we have, by the way. The depot injection is something we don't give to children less than 12 years old. You might be wondering about the potassium chloride. So potassium chloride can be a bit ulcerogenic, particularly because of the chloride part can cause ulcers. But because some first generation antipsychotics are strong anticholinergic, antimuscarinic agents due to their M1 receptor antagonism, this can delay gastric emptying and keep the potassium chloride in the stomach for a longer time, which can actually increase the risk of ulceration. Haloperidol for Parkinson's disease. So earlier we mentioned that D2 antagonists can cause pseudoparkinsonism and a whole slew of extrapyramidal side effects. And we mentioned this involves the nigrostriatal tract, where the part of the brain that degenerates in Parkinson's is also involved in this pathway. So it would make sense that if blocking dopamine in this area would cause Parkinson's symptoms, if you give this to someone with Parkinson's, it would worsen their symptoms. So this is something you really, in general, actually antipsychotics, we generally avoid them in Parkinson's. Now, the unfortunate thing is if there are certain people with Parkinson's who may actually have psychosis. We call this Parkinson's disease psychosis. And for that, none of the first generation antipsychotics have been evaluated as safe, especially those that are more potent, like haloperidol. You also have to be careful that if you do not taper, there may be rebound side effects. Rebound as in the symptoms might come back and they will be worse than before you started. That's rebound. Not just in terms of rebound psychosis, but even rebound cholinergic side effects, for example. Because some of these, like chlorpromazine, are strong anticholinergics. If you stop them abruptly, the opposite might happen in a much worse fashion, rebound cholinergic side effects, because your body was used to anticholinergic effects and then suddenly there is nothing blocking the M1 receptor. Rebound cholinergic, rebound dumbbells. So those are something you have to be careful about. And something we precaution service users now that there is a risk of medication shortage due to COVID-19. So there is an expectation that some people might not be able to access medication. So this is something we were trying to warn in advance. There's a lot of stigma with regards to antipsychotic medication, but in general, for schizophrenia, the benefits will outweigh the risks as long as, of course, the diagnosis is proper, adherence is ensured, and whatever side effects that can be managed are managed. Because later we'll talk about side effect management.